This woman that I told you about who encouraged me to look into RFA, her husband had died during surgery. Just felt like she couldn't put her family through that. She didn't want them, essentially to worry about her, and she didn't want to worry herself with this idea of having a surgery. With her hot nodule, radioactive iodine, I think there was some reason that she was really against that as an option as well. And so my hope, I think, for people in your audience is that they find, an endocrinologist or somebody who's able to take them through all these things to help them make the best choice right in the sweet spot for their individual circumstance.
Welcome to Save Your Thyroid, a podcast all about thyroid nodules. My name is Jennifer Holcomb, and I advocate for fellow patients suffering with this very common condition. Thyroid nodules impact 70% of adults in their lifetime, and the standard of care is surgical removal of half or all of the gland. But in recent years, safe and effective non-surgical treatment options have become available. In this podcast, I sit down with patients and physicians to discuss life with thyroid nodules, treatment options, and how to save the thyroid whenever possible. Today's guest is Dr. Christopher Fox, a board-certified endocrinologist practicing in Superior, Colorado. He has practiced in the Boulder area since 2003. He has a long-standing interest in helping people with all types of thyroid disease, including thyroid nodules and thyroid cancer. Over the past few years, he has developed a passion for combining endocrine science, psychology, personal development, and encouragement in new and creative ways to help people make meaningful, lasting changes in their health and vitality, especially as it relates to treating diabetes or promoting weight loss. In today's discussion, we'll cover topics such as his practice philosophy, thyroid and metabolic health, and adopting thyroid radiofrequency ablation as a treatment modality for thyroid nodules. Dr. Fox, welcome to the podcast.
Thank you for having me.
It's great to see you, and I am so happy to catch up with you. I know we've talked before. I would love to hear how things are going with RFA at your practice, but for the viewers, let's first start with a little background about yourself and why you decided to become an endocrinologist.
One of my mom's best friends when I was growing up was our pediatrician, my pediatrician. And she was just really, I think, instrumental in my life. We had a fairly close connection, and in a way she, I think, kind of inspired me. Was very much an encourager as I was young and getting curious about science and maybe thinking about what I would do. When I went to college with the thought that I would become a physician, and I really got fascinated with physics and went through a period of time where I had kind of shifted and thought I would be a physicist. But, as I went a little farther along, I think there was something about the people that I was training with in physics. Somehow our brains worked a little bit differently. And maybe in that specialty or in that field, there's a little bit less interpersonal connection. And I'm drawn to this idea of marrying science and people together. I pivoted. I went to medical school. I went with the idea that I would be a pediatrician. I did my pediatrics rotation as a medical student. And very quickly I said, I don't know what I'm going to be, but it's not that. Somehow it was different, I think, on the inside than it looked from the outside. I really fell in love with both internal medicine. So think of it as doctors for adults. Just by chance, my fourth year of medical school, right before I graduated, I took an endocrinology rotation. And I just thought that the material, the science, the physiology, it was just the coolest stuff. And there's lots of things about endocrinology, I think, that are maybe unique or different from some other adult medicine specialties. We see people through a whole age range. For me, about 16 years old, up into 80s, 90s, even a couple that have reached 100. And it's really varied. It's not just one organ. We talk about, thyroid today, but we also do things with diabetes or pituitary gland or parathyroid glands, pancreas, lots of different things. So it's not always talking about just the heart or just the kidney. And I think I've really come to enjoy that. It's been a good field for me.
I'd like to take a moment to thank the sponsor of today's episode, RGS Healthcare. RGS Healthcare has been a leading medical imaging equipment distributor for more than a decade. RGS is known not only for recommending personalized medical equipment solutions, but also for offering continuous support to ensure success. One thing RGS is particularly known for is unparalleled physician training and on-site staff support. They are the only medical equipment supplier known for accompanying their doctors to exclusive, specialized thyroid RFA physician training on live patients proctored by leading world experts. If you'd like to learn more about RGS Healthcare, please visit their website, rgshealthcare.com. A heartfelt thank you goes out to RGS Healthcare for supporting this channel. Now, back to the podcast. So, Dr. Fox, as an endocrinologist, then what drew you to decide to adopt RFA, a non-surgical treatment option for thyroid nodules?
I had training. I always remember we had this great mentor when I was an endocrine fellow. You go to medical school, you do your internship. As an endocrinologist, we do a residency in internal medicine. So that's typically 3 years beyond medical school. And then finally, there's advanced training in endocrinology, which is a fellowship. I did that in Virginia. I had a great mentor, Dr. Dunn. He's since passed, but he was a world thyroid expert. He talked a lot about iodine. And I remember the first time I worked with him in clinic, he introduced us to the ultrasound. He was about 75 at the time, but he said, one of the things that I want you all as fellows to come away from this training is the idea that you can't practice thyroid without ultrasound.
Yeah.
Because he thought it was such a game changer in terms of the ability to understand and help people who have thyroid issues. When I moved to Boulder, so 2003, I've been in practice in Boulder, Colorado for about 20 years now, bringing with me that idea that ultrasound was important. I was one of the first endocrinologists that really started using ultrasound here locally rather than sending folks to the radiologist, hey, go over there, get your ultrasound report, come back. Because it really is a neat tool. We actually see images right in real time, and we can compare that with what we feel with our fingers, and we can compare it with the story that we've heard from any individual patient. And it's really the marriage, probably overusing that term, the marriage of those things that really provides a lot of insight. And so here in Boulder, I built a career as maybe one of the thyroid go-to guys that I just saw a lot of patients who had thyroid issues, all flavors, hyperthyroidism, hypothyroidism, but especially thyroid nodules and thyroid cancer is where that ultrasound really shines. I've been watching the literature about thyroid RFA. It's been around for, more than a decade, probably 15, 20 years in South Korea and Italy, and kept wondering when it was going to come to the U.S. And
Right.
I forget the exact history, but I think it was cleared by the FDA in 2018. And I'd noticed it popping up in different places. And I kept thinking, gosh, I wonder when we're going to have that here in Colorado. And probably about 2 years ago, I had a patient come see me, and she was really interested in thyroid RFA. She had an autonomous nodule or a hot nodule, toxic nodule, a nodule that was overproducing thyroid hormone. And she didn't want to take radioactive iodine. She didn't want to have surgery. And she had researched this procedure, and we had kind of gotten to know each other. We'd been monitoring her condition for a few years, and it had progressed. And she said, well, hey, Dr. Fox, why don't you do it? Why don't you learn how to do RFA? And it was like this little light bulb went off. And honestly, I had never really thought about it before then. I ended up doing a little bit of research and kind of looking into the procedure, talked with a mutual friend, Rudy, who handles a lot of the RFA equipment, essentially learned that the skill set that I had, so probably at that point had done 10,000 ultrasounds and 3,000 or 4,000 biopsies, that skill set is the skill set that's needed for RFA. It's just a little bit more prolonged, the RFA procedure. So with that, I kind of got excited about it and went to Johns Hopkins to take their RFA class, to spend time sort of in the presence of the experts, the people who have been doing this for 5-6 years in the United States, and learn from them. And then we had these wonderful practice sessions where we got to actually do hands-on. And at that session, I learned how to build essentially a fake thyroid out of chicken and jello. It's not very fancy, but what we call a phantom, to be able to do some practice sessions on my own, and ultimately made the decision that, this really could be a wonderful procedure for our patients, because there really are many people who might benefit from this procedure for whatever reason, personal preferences or life circumstances or medical conditions where the standard treatment with surgery may not be a good option or may not be their choice. And anyway, so that's what led me to start doing the procedure. And I think as of this point, I'm still relatively new to the procedure. We've done 10 cases in my clinic, really starting to see some wonderful results, and people are pretty happy with this option.
That's great. I'm trying to remember, did I actually meet you at that Hopkins course?
That's where we met. Yeah,
we met in
at
person there? Okay,
we
I
met in
couldn't
person
remember.
at the Hopkins course. Yes, yes. I feel like we had maybe had one interaction or something before then, because I knew of you. And then we had a chance to meet in person there. Yeah, so it was wonderful to be able to hear about you and your family and your own personal experience there.
Well, thank you. And I appreciate you sharing all of the background that kind of led you down that road toward RFA and your ultrasound skills. That is something that I am learning. I've actually never personally seen an endocrinologist, believe it or not. For my whole treatment journey, my local doctor was an ENT. My doctor that performed my RFA was an interventional radiologist. And so I've never seen an endocrinologist. And actually here where I live, there are not very many endocrinologists. And most people in this area travel either to Nashville, Tennessee or Birmingham, Alabama. I split the difference between those two cities to see endocrinologists at Vanderbilt or UAB. And so I've never seen an endocrinologist, but I was not aware until I became very active in the community that I serve that endocrinologists don't routinely do ultrasounds. And so for you to hone in on that skill early on in your career and, just develop your skills there and your passion for seeing. And also, I love when you said that, combining that with the patient's story, because that's important too. You're not only looking at images, but you're listening to what the patient is saying and kind of using those, putting those puzzle pieces together. That's so important, and not just relying on, what lab work and things like that say. So I wanted to touch back on a couple of things you said there, Dr. Fox, because you said several things that really piqued my interest. You mentioned that your mentor talked about iodine a lot, and that really sparked my curiosity. What exactly was his position on iodine? Because that's kind of a topic of controversy these days when it comes to thyroid.
Yeah, so Dr. Dunn, my mentor, he was about 75 at the time that I was in training with him, and he had made his career learning knowledge and treatment of iodine deficiency. Mm-hmm. And so he traveled the world going to all different regions and would actually help communities institute iodine replacement into their communities to avoid really the tragedies that happen, particularly in newborns, when iodine deficiency is present in the population. Iodine is it is kind of a topic of controversy in the U.S. And in a way, it's probably more straightforward in that the vast majority of people in the U.S. actually have sufficient iodine intake to meet their needs. The one exception that comes up from time to time where there's a little bit of additional stress in the body is in women when they're pregnant. And that's a time, I think, in particular to make sure you're getting enough iodine. But he just really had this wonderful love of the thyroid gland that he kind of infused into all of us, his trainees.
Yes, a lot of patients don't realize that iodine is what the thyroid uses to make thyroid hormone. So that's interesting that he spent a great deal of time promoting that information. You mentioned your patient that inspired you to adopt RFA had a hot thyroid nodule. Do you know anything about how these nodules suddenly develop the ability to start producing excess hormone? Is that something that just happens at random, or is there a known cause for that?
So yes, there are some known causes, and nodules just in general. So the thyroid gland being, I'm sure your audience is very familiar, a little butterfly-shaped gland that lives in the neck, makes these hormones called T3 and T4 that are built using iodine molecules. So the 3 and the 4 in those
Mm-hmm.
names are actually the number of iodine atoms that are in those specific molecules. The thyroid gland, as we get older, for reasons we don't totally understand, can develop a lumpiness. I'm in my mid-50s now, and I'm finding that lumpiness, unfortunately, is something that seems to come with aging. And so I think the
Mm-hmm.
thyroid gland is susceptible to that.
Mm.
But one particular flavor of nodule is a nodule that will overproduce thyroid hormone. So the vast majority of thyroid nodules, probably 95%, what are called cold nodules, if you read about them, are non-functioning nodules. They're a lump, but they actually don't produce thyroid
Right.
hormone. An autonomous nodule or hot nodule overproduces thyroid hormone, and it's just related to some genetic mutations that happen in a few thyroid cells. So they acquire the ability to produce thyroid hormone without needing to receive that normal signal from
Mm-hmm.
the pituitary gland. Over time, those nodules will proliferate or grow. And so they don't usually come to attention until they're big enough to actually either be detected clinically as a lump or by producing abnormal thyroid blood tests or hyperthyroid symptoms, heart
Mm.
racing, anxiety, depression. A lot of times when people ask me that question, they want to know, what can I do to keep this from happening? Or, hey, I have a nodule, how can I make it go away? And, unfortunately, we don't know how to eat more broccoli or, do yoga or stand on your head and make these things go away or stop
Right.
producing thyroid hormone, which is where treatments like thyroid RFA come into play.
Yeah, we have a lot of patients who come to the community, and that's the first question they ask is, how do I get rid of this thing on my own? I don't want to have surgery. The whole 4 years that I've been doing this, and prior, it's been almost a decade that I've been addressing my thyroid nodules. I have not encountered any lifestyle changes that make meaningful impact. I've seen a lot of things that have been studied that indicate that it could have impact, but I personally haven't experienced those things myself. One thing I am reading about somewhat right now is selenium and the importance of that mineral. Do you have experience with that in your experience?
So selenium, it comes up with thyroid a fair amount, and it
Mm-hmm.
may have a role, but I don't know that it will have a role for what we're talking about today
Mm-hmm.
when we look at thyroid nodules.
Mm-hmm.
So selenium is simply a mineral like calcium or magnesium. You can find it in the world. It exists in foods. The classic thing is nuts. Brazil nuts is the
Mm-hmm.
one that people often read about, have a lot of selenium. But selenium is actually part of the enzyme that converts thyroid hormone T4 into T3 or deactivates T3 into something called T2, which we don't generally talk about. There are some studies for people who have autoimmune thyroid disease, Hashimoto's, that
Mm-hmm.
selenium is one of a few things that is thought possibly to slow the pace of that autoimmune reaction. So when somebody comes to me and says, I feel fine, my thyroid numbers are good, but I have these antibodies that my doctor found, and I
Mm-hmm.
don't want to get hypothyroidism, what can I do? Selenium, and the dose in the studies typically is 200 micrograms per day. There are some small studies which say that may be helpful.
Mm-hmm.
And there's probably very little downside to
Right.
taking that. So it is something that I share with people. I'm not confident enough to say that everybody who has autoimmune thyroid
Yeah.
disease should be on this, but I think particularly for your audience, I'm sure as a more proactive group, this is something that might be helpful. I haven't seen any studies that show that selenium changes the course of autonomous thyroid nodules, hot nodules, or just the shape or size of normal thyroid nodules.
Yeah, and I think that kind of matches up with our experience as a community too, is we've not really seen anyone have significant impact from making changes like that. But, one can hope that at some point down the road, maybe there'll be some research that we can look back on and say, in addition to things like RFA, which absolutely are a game changer, maybe there are these other things we can add in on top of that that will be beneficial. We'll see. Time will tell, I guess. So let's kind of circle back then to RFA. Talk about how are you performing this procedure in your practice? Kind of describe like what it's like for the patient that comes in and how the procedure process works.
To take somebody through the day when they come, we send them home before they come on their treatment day. So when we've talked about the procedure and met and decided to go ahead with this, we've sent them home with some particular instructions, some very basic things like wearing comfortable clothing and just because of the way RFA works, important that you don't have metal on your body. So no earrings, no underwire bra, no piercings. So we want all that metal off. And so when somebody comes to meet us, we bring them back just to an exam room. We usually just have a chat. We talk about the risks and benefits, again, of the procedure, go through the consent form, the thing that the lawyers want you to sign that takes you through all the particular risks. And we'll migrate sort of across our hallway into the treatment room. Staff will help this person get ready. So typically at that point, they've changed into, we just have some comfortable clothing in the office that is good for the procedure, like, pajamas almost, that they can be in during the procedure. There are these two electrical pads that go onto the thighs, which basically, when we do that RFA and we're putting electricity into the body, just like you learned in physics class, going back to the physics thing, we need to make a circuit. So it's got to have somewhere to go. So it comes out through these pads. Out of our 10 cases, 9 of them have been women. So we've only had one fella, but sometimes we talk about whether you want to shave your thighs to avoid pulling the hair off on those areas. At that point, basically, we try to get comfortable on the table. So we have some bolsters or pillows to put behind the neck or behind the knees, blankets. We just make sure somebody is comfortable. And then I'm going to spend a few minutes just taking the ultrasound to look at the neck, make some markings of sort of where the landmarks are. What's the top of the nodule? What's the bottom of the nodule? What's our entry point? There are some kind of obnoxious little veins that run right down through this field. And it's not the end of the world if you hit one, but it does make it bleed quite a bit more. So we try to steer clear of those if at all possible. Then once we're ready for the procedure, we get this area cleaned and we get the area draped. So there's a little bit of a sheet that comes up. We try not to cover the head too far because we don't want to create a claustrophobic feeling, but we're just trying to keep this area sterile and clean. Most people prefer to wear an eye mask. The way the procedure works is I'll be sitting at somebody's head. So if I was the patient lying down here, I would be sitting up here with my hands coming around the neck this way to do the work. And so there's just things kind of moving back and forth this direction, which I think can be a little unnerving if you're watching the whole thing. And so most people have chosen to wear the eye mask. We have some just safety glasses if somebody wants to be able to watch and prefers that. The first part of the procedure is where we spend some time getting this whole area numb. So we numb the skin. Most of the pain fibers in the thyroid gland are right along the edge of the thyroid gland in what's called the capsule. And so we'll spend a little bit of time just inserting a needle down right onto the top of that capsule to spread some numbing medicine or lidocaine across the front of that capsule to try to get that nice and numb, which really makes the procedure tolerable for people so that they're not, uncomfortable during the procedure. Once we feel like that's numb, then we spend time doing the actual RFA. It's a pretty straightforward procedure. So if there's a nodule that's sitting there, we basically insert a nodule at a particular angle. We try to get down to the far end, and then we turn on the ablation. So the electricity, that creates some vibration in those molecules, that creates heat, which destroys that thyroid tissue. And so we just move that needle sort of back along a track and systematically through to try to ablate each part of the thyroid gland. And if we think about this in 3 dimensions, we then kind of work from the feet to the head, each of those levels kind of doing it the same way. And most people's thyroid nodules, 4, 5, 6, 7 centimeters have been what we have. So it's usually, in terms of those little sections, maybe 4, 5 sections would be pretty standard. The actual ablation usually takes about 45 minutes of actual time and maybe 20 to 25 minutes of the needle is on ablating that tissue. And one of the neat things about RFA is the patient, if you're having this procedure, you're awake the whole time.
Right.
There's actually some things that we want to be able to know. One of the complications that we want to make sure we don't run into is damage to the nerve that controls the voice.
Yes.
And so we want to be able to hear your voice as we're going to know if we're inducing any changes. And then, as I've learned, there are things we can do to make the procedure more comfortable as we go along. So it seems that a lot of people, in my experience, are a little bit more sensitive or can feel a little bit more when we're right at the edge of the nodule, which makes sense. Sometimes toward the end of the procedure, if we've been going for a while, maybe that numbing is starting to wear out, and we might want to think about putting a little bit more lidocaine in just to finish the procedure. I can't remember if you had told me that your doc did this with you, But sometimes in the middle, I think you had mentioned it to me when we were talking about ways to do the procedure, sometimes just a break of 2 or 3 minutes, a timeout, just
Hmm.
to let everybody catch their breath actually really does well as well. Let some, the patient kind of wiggle the shoulders or just get a little of that muscle tension that's out. Once the procedure is done, small Band-Aid to make sure that it's not bleeding. We usually keep people in the office for about 30 minutes, usually a cup of tea or juice if you want something like that. We chat a little bit about what to watch for when you go home, and then you go home that same day, usually after about 2.5 hours in the office.
That is very similar to what I experienced myself. And, when you were talking about numbing the thyroid, it's very interesting because, and I was speaking with another doctor about this, about how the first little prick of the needle is the worst part because it feels kind of like a bee sting. But after that, once that lidocaine takes effect, you really are very, very comfortable. And I did not even realize that my doctor had begun ablating until he asked me, "How are you feeling?" And I said, "I'm fine. Have you started yet?" Makes it so much more comfortable. And even I had a biopsy at one point in the past without any lidocaine. I will never do that again. so so definitely lidocaine helps things tremendously. And you said you've had about 10 patients that have undergone this procedure so far. How many of those have been your current patients versus those coming to you who found out Dr. Fox is doing RFA now? I'm going to go see him.
Yeah, goodness, good question. If I reflect back, the vast majority have been the second category, people that have found out that we're doing
Mm-hmm.
the procedure and have come specifically to talk about it. Probably just two who were existing people in the clinic, and the other eight then would be people who have come to seek it out.
And it's not uncommon in our Facebook community. People join, and the first question they want to know is there a doctor in fill in the blank city? So that makes sense to me then that they would be, looking for you. And so it's so wonderful that you're now doing this. Regarding thyroid care, since this is a thyroid procedure, how much of your practice is dedicated specifically to thyroid? You said that was something you are particularly passionate about.
On any given day, I've never actually broken down and done the actual math, but I would say probably 50%, maybe 60% of the people that I see on a given day have some variety of thyroid issue. Hypothyroidism would probably be the most common, but hypothyroidism, hyperthyroidism, nodules, or cancer. Yeah, I think each of those, has been kind of a challenge and a joy and has its own unique issues for folks living with them. But yeah, 50 to 60%.
Well, with that in mind, let's kind of think about metabolic conditions and their overlap with thyroid conditions. Do you see kind of a connection between metabolic conditions like diabetes, PCOS, or any other conditions where you tend to see more thyroid nodules in those particular patients?
Yeah, it's a great question, and it's one of those things where thyroid nodules happen so commonly. Sometimes it's
Yes.
hard to know what is cause and effect. So
Right.
by the time they're more common in women than men, by the time a woman reaches age 50, we find at least 50% of them have at least one nodule if we look carefully
Hmm.
with the ultrasound. But the thyroid and thyroid nodules do seem to be sensitive to this hormone insulin. And so thyroid cancer is known to be one of the cancers that does seem to be associated with overweight or obesity and this thing called insulin resistance.
Hmm.
I know you had mentioned perhaps in your population that PCOS is a common condition
Hmm.
that comes up, and it is thought to be statistically more likely that women with PCOS have more thyroid issues just in general, all types of thyroid issues, including hypothyroidism, but also thyroid nodules. And so I do think that there is a role that's there, and it's probably an encouragement for all of us. There's this adage, what's the best day to plant a tree? 20 years ago.
Right.
What's the second best day? It's today. So
Hmm.
there is a little plug here to say, thinking about metabolic health, and that's kind of a mouthful, but we're talking about things like good nutrition, trying to maintain a healthy body weight, trying to exercise in a consistent fashion. Really, over the last 10 years, we've learned a lot about quality sleep feeding into this as well. And so
Hmm.
having those things as a focus, it can be really difficult in the challenges of one's life, right? Being a maybe a working mom or CEO of a company or whatever the role is. You're trying to do all these things that you know you're supposed to do and maybe you just don't have time to, or at the end of the day, you're tired and you don't feel like it. But
Hmm.
all of that just to say it's a plug to think about these things because like so many conditions, prevention is so much better than treatment. And
Definitely.
trying to have those habits make improvements, even if you can't go from 0 to 100%, or 10 to 100%, if you can go from 10 to 40%,
Hmm.
that's going to be measurable in terms of your health. So I hope that's useful.
Oh, definitely. My husband just recently had his annual physical, and he told his doctor, "Yeah, I walk 10,000 steps a day." And I thought his doctor would be impressed with that, and he said his doctor was not impressed with that. He said that is not anywhere near enough activity to counteract the amount of sedentariness that someone who works in a desk job has in their life. And so, we kind of sometimes dismiss the whole concept of, oh, I need to eat better and exercise because we don't think, well, surely that's not going to be that important, but it is very important. I love that you have this focus in your, as I mentioned in the introduction, that lifestyle changes are very important. What are the things that you really focus on the most as far as lifestyle changes?
It's really different for each person. And, it's something that I think the medical profession gets a bad rap. I'm just thinking about your husband and his interaction. I think sometimes folks go to the doctor and they feel like all you get is this, it's like a spanking almost or something,
I think he
like,
was at
hey,
least nice about it.
yeah. I certainly hope so.
Yeah,
Certainly hope so. But I do know that there are folks who go and they're told, "Oh, you're doing this wrong. You're doing this wrong. You're doing
sure.
this wrong." I think as humans, our brains are kind of wired to look for what's going wrong. Sometimes it's
Hmm.
helpful to actually look for what's going right. We actually in our practice have what we consider three pillars of physical health and three pillars of mental health, and this is the framework that I use to think about people. It may not be perfect. But on the physical side, it's just nutrition, exercise, sleep. Trying to choose healthy foods in the right portions to meet your body's nutritional needs. So it has the substrate, the chemicals that it can use to run properly. Exercise, it's one of those things where up to a pretty high point, more seems to be better. But for a lot of people, we talk about this benchmark of 150 minutes in a week. So that's 30 minutes on 5 days, like a brisk walk, something where you're feeling a little bit out of breath. You can probably still talk, but don't really want to. And then sleep, I think more people struggle on the not getting enough sleep, either because they have sleep issues, insomnia, sleep
Yeah.
apnea, restless legs, or just because life is busy and you just don't give yourself enough time,
Hmm.
in bed. We think about 7 hours of sleep is probably a minimum for most people. And that's actually 7 hours of sleep time, which means you've got to be in bed a little bit longer to
Right.
allow for those times when you're not sleeping. On the mental health side, we talk about stress management, definitely worthwhile to think about. And then kind of interestingly, things that seem to relate to having a good life are good relationships and a sense of purpose, a reason to get up in the morning. Those things come up as well from time to time.
I love that. It's important to keep all of those things in mind. When someone comes to this place of, I have this thyroid nodule, it's got to be dealt with, they're thankful that, they can have this procedure, address this thyroid nodule, and then continue working on all of these other things that are so important because we don't want to just focus on one or the other. It's a whole picture for our health. So you mentioned that you have this philosophy in your practice of the sweet spot. Tell me what that means to you and how you came to adopt that philosophy.
Yeah, this has come through a kind of longish career in medicine. Do I have time to tell a little story?
Of course.
So when I was still in Virginia, my wife was pregnant with our first child. So this is 21 plus years ago. And I developed a hernia and needed surgery. And I'd only had one other surgery in my life. In that other surgery, I remember that at an academic center, if any of you have been there, you meet all the different levels, the intern and the resident and the
Hmm.
fellow and the attending physician. But the attending physician had come down in the morning and said, hey, I just want you to know I'm here. I'm going to be there. Everything's going to be great. Anyway, contrast that with my hernia surgery in Virginia, where really the only person that I saw on the morning of surgery was the intern. And I think it was in August, so he was pretty new. They all start in July. When I wheeled into the operating room, there was a physician who was there. He was doing some stuff with equipment. He was walking around, but it was really weird, Jen. He never came and introduced himself to me. Yeah, we had zero interaction. And I just
Wow.
remember kind of felt like I'm just I'm hernia number 237 for this guy, just a
Right.
piece of meat or something there on the table. As I was getting put under anesthesia, so general anesthesia, went to sleep, I remember there was a nurse and she was rubbing my shoulder as I went to sleep. And I just remember how peaceful and comforting
Yeah.
that was and how good that made me feel. So long-winded way to say that there's more to medical care than just knowing the right thing or being able to do the procedure well. But there's this idea of actually care, right? Caring for people and that relationship that develops. And as an endocrinologist, that's become very important for me. So sweet spot is basically that we have all this medical science. This is how the thyroid works. This is why nodules happen. Here's the size of your nodule. Here are the things we can do for it. And then on your side, you have your own individual values and preferences and desires and goals. As we're talking about some of these metabolic things, time budget, energy budget for what,
Yeah.
you're able to do. If you're supposed to do all these things, how much can you do?
Yeah.
And so I think of the sweet spot as the spot where those two things kind of come together, right? In the science in your life. And I like to try to help people find that and to live in that spot because I think there's a lot of value for each person's individual health when we can be in that place.
I absolutely love that. And I can tell just from talking to you that you are very invested in bringing all of these things together in your patients' lives and in their care. So thank you for sharing that. Do you have any comments about how RFA is changing your endocrinology practice?
RFA, I think it's just a really nice option that we have for people who essentially have, so most commonly one of two main issues, right? A symptomatic benign thyroid nodule, so a nodule that is big enough that it's causing discomfort for the way it feels. You notice it when you swallow. It's really bugging you enough to think, hey, I think I'd like to do something rather than just live with this. Or an autonomous nodule, a hot nodule, one that's overproducing thyroid hormone. It just brings a different approach. It's a different option for people that has kind of a different set of pluses and minuses. So we know that with RFA, the likelihood of developing low thyroid function afterward is pretty much near zero. We expect to be able to preserve normal thyroid function. So for somebody who's not on thyroid hormone, we don't expect you to need thyroid hormone after this procedure. It doesn't require going under anesthesia, having a surgical scar, having the recovery that's associated with that. This woman that I told you about who encouraged me to look into RFA, her husband had died during surgery.
Oh my
And
goodness.
she just felt like she couldn't put her family through that. She didn't
Yeah.
want them, essentially to worry about her, and she didn't want to
Right.
worry herself with this idea
Yeah.
of having a surgery. And I forget why, with her hot nodule, radioactive iodine, I think there was some reason that she was really against that as an option as
Yeah.
well. For this, it's something to say that we have these other options, right? We have the watch and wait option, which can be fine for many people. We have the surgical option, which we know in good hands has good results. And we have a lot of great surgeons here in the area that we send folks to for those hot nodules. We do have radioactive iodine. And so my hope, I think, for people in your audience is that they find, an endocrinologist or somebody who's able to take them through all these things to help them make the best choice, right, in the sweet spot for their individual circumstance.
Definitely. And I'm sure in your long career, Dr. Fox, you've probably helped a lot of patients after thyroidectomy have to manage their thyroid hormone. Have you seen patients go through a lot of difficulty with that?
I think starting thyroid hormone after thyroid surgery, it's one of those things where for some people it's super smooth and we get it right with the first dose and everything's wonderful and they're, hey, I'm good. See you in a year. But definitely there are a number of people, for whatever reason, who either take a little longer to find that right dose of thyroid hormone. A subset of people, probably 20%, who will say, even though my numbers look good, I know my TSH is 1.0, something's different
Yeah.
in me. I just feel different before surgery to after surgery. Having somebody to look into, perhaps this idea of T3, T4 combination therapy. There are different ways that we can give thyroid hormone that maybe
Yeah.
aren't endorsed by all of the scientific organizations, but there are some scientific studies that show for the right person. And this has definitely been my experience that there are some people who respond wonderfully well to giving thyroid hormone in a different style. And so we do have some folks that, we can take 6 months or a year to really find the right thing. And in the background, I think we always wonder, well, if you're not feeling well, is it all the thyroid, or maybe we need to be looking at other things. Maybe there's something else going on, iron
Sure.
deficiency or anxiety or depression or something else that also needs treatment for you to be at your best.
Right. And just knowing that you could maybe potentially avoid being one of those 20% who have trouble adjusting to thyroid hormone by having this type of procedure instead, that's a good option too. For me personally, I am someone who either immediately upon starting a new drug will have a reaction. I just don't do well. Or I'll take it for a period of time and then it'll just stop working. And so that was a big concern for me personally when I was thinking about having thyroid surgery was, am I going to battle that for the rest of my life? I worried that that would be a problem for me. I have a friend in particular I'm thinking of right now who has hypothyroidism, and she's been hypothyroid since her 20s and now she's in her 40s and she's still constantly having to adjust her dose. So, it's a lifelong battle that, some people would prefer to avoid it if they can. So that's one of the best things that I've found personally about this procedure for me.
It is a nice selling point, yes.
Well, then let's move on to the questions from the Save Your Thyroid community. So the question is, on a large nodule of 10 centimeters where the nodule is taken over the whole lobe, how do you know where to ablate? And the second half of the question is talking about a 10 centimeter heterogeneous lobe suspicious for follicular cancer. I'm guessing that would not be a candidate.
One of the questions that people ask me a lot in the follow-up of thyroid nodules is do I need to worry about my nodule turning into cancer? Benign nodules really don't turn into cancer. If you have a cancer, it will typically start as a small cancer that will then grow. If you have a nodule, we do a biopsy and it's benign, then we can expect that nodule likely will stay benign. It's not going to turn into cancer. If it does grow, often we take a second biopsy just to make sure we didn't somehow get the wrong answer the first time. But after 2 benign biopsies, American Thyroid Association says we don't need to keep doing biopsies to look for cancer. So this would just be reassurance for those of you who've had benign biopsies that your nodule is not going to turn into cancer. It shouldn't metastasize. And so it just needs to be treated as a benign nodule, really making that decision, do I need to do something about it? And if I do I want to do surgery or RFA or potentially radioactive iodine for an autonomous nodule? Now, for those nodules that are cancerous, the gold standard has always been to remove that surgically. And I think that RFA is being looked at more and more as, like I say, an option for small cancers. If somebody had a 10 centimeter nodule that was thought to be cancer, 100%, I would tell you, please go talk to your surgeon and let's get that out so that you can get a definitive diagnosis and the appropriate treatment to take all of those cancer cells out of your body, because it is almost impossible in that situation to expect that RFA is going to completely treat that. One of the other questions that comes up is, thyroid biopsy is not perfect. And sometimes we end up in this in-between stage. They say, I had this nodule that was suspicious for a follicular neoplasm, or it had atypical cells of undetermined significance. Maybe you've had some advanced testing with molecular testing through Afirma or Interpace or ThyroSeq to say, can we characterize the risk of that nodule? And I know that there are places in the US that are starting to look at whether those can be treated with RFA in some circumstances. For me right now, there hasn't been any scientific study that says what the right answer is. And so for folks of yours that might fall into that condition, I would encourage them perhaps to look for a place which is doing one of these studies to see if they might qualify, and perhaps that would be a good option in that circumstance.
When you were talking about the big 10 centimeter nodule not being able to completely reduce it, that was my experience. My nodule wasn't quite that large, It was about, I want to say 4.5 centimeters wide by about 6 or 7 centimeters long. So it was pretty big. And even though my two treatments went very well, he treated as much as he possibly could, I still only received 90% reduction. Now I say only, 90% is very, very good. And I'm very thrilled with that result. But still, it's not complete elimination of the thyroid nodule. So I can understand what you're saying there about if this is a cancerous nodule and it's that large, we're not going to be able to eliminate it. And that's very important with cancer. So thank you for addressing that. Dr. Fox, do you have any final thoughts you'd like to share with the community?
We've talked a little bit about endocrinology along the way and ultrasound, and I guess I would just encourage your community to be an advocate for finding a physician, whether it's endocrinology or ENT or general surgery or something else, but a physician that you can trust, somebody that will get to know you and your circumstances and can help guide you through this increasingly more complicated world of medicine and healthcare. I heard recently that the science of medicine doubles every 70 days or something crazy.
Wow.
Like that. I mean, the knowledge is just exploding, right?
Yeah.
And so it's very hard for any one person to keep up with that. And then we have this healthcare system that most folks know is kind of struggling and crazy and full of all sorts of quirks and idiosyncrasies. And so, yeah, my hope or my encouragement is that each of you will find somebody that you can relate to. Like I say, we'll take the time to get to know you and can help you navigate this healthcare system, your healthcare concerns, and hopefully help them align with what you need and want in the moment.
Dr. Fox, that's so important. And it's so encouraging to hear that from a physician, because I think so many patients don't feel like they have that. They feel like it's almost kind of a battle between, me versus the doctor. And I always feel like that's so unfortunate, but I've also been through that myself personally. And so when you do finally, as a patient, find that doctor where you can develop that really trusting bond and relationship where you're working together, and the doctor is listening to you as you advocate for yourself. The doctor is wanting you to advocate for yourself, being open to discussing these new things that are becoming available as treatment options. Those are things that patients are so happy and excited to hear about. So thank you, Dr. Fox, for just sharing with me all of your philosophies of practice, sharing your passion with me of how you address treating patients in medicine today. Thanks so much for listening. Please share this content and help others. If you need resources, testimonials, and support, please join our patient community. Save your thyroid. You can also find me on social media and Substack under the media handle It's Me Jen Again. Never forget to educate yourself and be your own advocate and save your thyroid.